This lecture will cover the pharmacologic management of migraine headaches. Objectives for this lecture include describing the difference between preventive and abortive treatments of migraine headache, identifying medications that are commonly used to treat and prevent migraines, differentiating the appropriate use of NSAIDs, opiate analgesics, ergot alkaloids, and serotonin receptor agonists, otherwise known as triptans, for the acute management of a migraine, recommend appropriate situations for initiation of prophylactic therapy, and list 3 common side effects and 2 common precautions associated with each preventive and abortive migraine headache medication. You should be familiar with the background physiology and pathophysiology associated with migraine. I'm not going to cover migraine triggers in depth, but please recognize that there are many triggers that may put a patient at increased risk for development of a migraine. These can include triggers within the behavioral or environmental, as well as food triggers. There also are some medication triggers that patients may experience that may make their headache worse or may precipitate a headache. These include H2 receptor antagonists such as famotidine or ranitidine, proton pump inhibitors such as pantoprazole, estrogen and oral contraceptives, nifedipine, nitrates, reserpine, which is a very old agent which I have never seen used clinically in practice, theophylline, or because of withdrawal due to the overuse of analgesics, benzodiazepines, decongestants, or ergotamines. This list is not at all inclusive. Headache is listed as a potential adverse effect for a wide variety of medications. The medications on this list do pose an increased risk. However, there are many other medications which can cause headache as well. So you do need to do a good assessment of your patient in order to identify if they're having other medication-related causes. Estrogen and oral contraceptive use has the potential to precipitate new onset migraine. It can exacerbate pre-existing migraine, and it has the potential to change the migraine pattern. These changes will typically go away when the combined oral contraceptive or estrogen preparation is discontinued. In addition, women who experience aura with their migraine, if they do use an oral contraceptive, they are at an increased risk for cerebral infarction or stroke. This is a relative contraindication, not an absolute contraindication, but definitely something that you need to keep in mind when prescribing estrogen or oral contraceptives for your patients. You do need to closely screen for other stroke risk factors to identify the risk-benefit of using an oral contraceptive in a patient who experiences migraine with aura. In all women who do experience headaches or migraine, if an oral contraceptive is used, you do want to try to choose one that has a low dose of estrogen or a progestin-only product. Triphasics may be the least well tolerated. These do have differing concentrations of estrogen over the course of a woman's cycle. Women can also skip the placebo week of their pill and continue with active pills for 3 to 4 months at a time. It is this decrease in estrogen during that withdrawal during that placebo week that can precipitate the migraine. So what can we do for abortive treatment in these patients? The goals of abortive therapy include reducing the headache frequency, severity, duration, and disability, reducing reliance on poorly tolerated, ineffective, or unwanted acute pharmacotherapies, improving the patient's quality of life, avoiding the escalation of acute headache medications, educating and enabling patients to manage their disease to enhance personal control of their migraine, and reducing headache-related distress or other psychological symptoms. In order to meet these goals, we do want to use migraine-specific agents for patients who experience moderate or severe migraine, or for patients whose mild to moderate headaches respond poorly to NSAIDs or combination analgesics. A migraine-specific agent includes either a triptan or an ergotamine product such as dihydroergotamine. Patients should be educated to treat their migraine at the earliest onset of symptoms. Failure to use effective treatment promptly may increase pain, disability, and the overall impact of the headache. We also need to select an appropriate route of administration. Many patients who experience migraine may also experience nausea and vomiting. For those patients in which nausea and vomiting is severe, a non-oral route for their medication may be more appropriate. We also need to think about utilizing an antiemetic for patients who may experience vomiting or may be likely to vomit or experience nausea along with their headaches. We also need to guard against medication overuse headache. Many experts limit acute therapy to 2 headache days per week. Patients who do experience medication overuse headaches should be on preventive migraine therapy, which we'll talk about a little bit later. There are a lot of non-pharmacologic options to help manage a patient who is experiencing a migraine. However, drug therapy is still the mainstay of treatment for most patients. Many of these strategies are used for preventing migraine episodes rather than for alleviating symptoms once an attack has begun. For example, if patients have identified food triggers, they can adjust their diet to avoid these triggers. Getting good quality, consistent, and adequate sleep is also good at preventing migraines from occurring, as is regular exercise. Patients can use biofeedback both as a preventive and potentially as an acute treatment option. They can use relaxation exercises such as stretching, progressive relaxation, or guided imagery. Physical therapy that emphasizes stretching and strengthening of the head and neck muscles may be helpful from a preventive perspective as well. Acupuncture and acupressure may help. Ice may help. Massage, trigger avoidance, stress management, and then rest or sleep in a dark and quiet environment. Some people do benefit from caffeine, especially during an acute attack. However, we do need to use this with caution because caffeine may interfere with sleep. So if some people, they do respond well to sleeping their migraine off. It helps to alleviate some of the pain. The caffeine may interfere with some of that. Pharmacologic treatment of acute headache should be started early to abort the intensification of pain and to improve response to therapy. Abortive therapies are most effective when administered at the onset of migraine. Patients should be taking an adequate dose of an appropriate abortive therapy at the first sign of their migraine headache. The severity of headache will increase with time, and drug therapies are most effective when they're started early. We should be selecting medications based on the headache severity. There are several ways that patients can rate the severity of their migraines. Some providers will use a 10-point scale with 0 being no pain, 10 being the most severe pain, or a 4-point scale with 0 being no pain, 1 being mild, 2 being moderate, and 3 being severe. Mild is often described as a headache that has minimal disruption in the patient's usual activities. A moderate severity headache will often lead to moderate functional impairment. And with a severe headache, patients may be unable to perform usual activities or can function only with severe discomfort and reduced efficiency. At this state, patients may often be bedbound because of their headache. For mild to moderate migraine, here are some treatment options listed in the order that they should be tried. Simple analgesics would be first line. Acetaminophen is included on the list. It is an option and some patients may respond. However, there is not a lot of data to support its efficacy. If it is used, it should be at an adequate dose, so something around 1,000 milligrams. Patients may respond to the combination product of acetaminophen, aspirin, and caffeine. And this is also marketed under the brand name of Excedrin or Excedrin Migraine. this would be a very good first-line agent for patients who have mild to moderate migraine. NSAIDs are also a reasonable option. However, you do need to remember contraindications. Patients who have renal disease, any type of gastric ulcers or bleeding, patients who have aspirin hypersensitivity may not be the best candidates to be treated with an NSAID. Combination analgesics, such as the combination product of aspirin or acetaminophen with butalbital and caffeine, plus or minus codeine. This is marketed under the brand names of either Fiorinol if it contains aspirin or Fioricet, which contains acetaminophen. There are no randomized controlled trials to support the use of butalbital in migraine. However, you will see these combination analgesics utilized to manage migraine in some patients. If these simple analgesics or combination analgesics do not work for patients, we can progress to more migraine-specific therapies such as the triptans or dihydroergotamine. Ergotamine, opioid combination analgesics such as hydrocodone and acetaminophen or oxycodone and acetaminophen, and butorphanol nasal spray may be options as well. We do need to watch out for medication overuse headache if patients are using their simple analgesics or their opioids too frequently, and also if they're using their migraine-specific medications too frequently, they can develop what's called medication overuse, which basically they may develop a headache as a result of withdrawal from their short-acting analgesic agents. It is recommended that patients limit their migraine therapies to 2 to 3 days per week. For patients who experience severe migraine, a migraine-specific agent is going to be recommended first line. This would include any of the triptan agents, dihydroergotamine or ergotamine, or opioid combination analgesics, or butorphanol. Key points to think about when utilizing an opioid in a patient who presents with migraine headache. Opioids are effective, however, they should be limited to patients who have moderate to severe infrequent headaches in whom conventional therapies are contraindicated or if they've failed conventional therapies. Frequent use of narcotics can result in dependence and rebound headache. We want to minimize their use to prevent tolerance, physical and psychological dependence and abuse. Again, there is a risk of medication overuse headache. We should be reserving these as a last resort. However, they are effective in an appropriate patient population and they can help to relieve pain. They also may help to promote sleep, which may help resolve the migraine independent of any drug therapy that's utilized. So again, we should be limiting these to patients who have moderate to severe infrequent headaches, have contraindications to, or have failed conventional therapies. So let's look at an algorithm of how we should be managing patients who present with migraine. After migraine is diagnosed, we then want to do some patient education regarding a general wellness program, including avoidance of triggers, appropriate diet, exercise, regular sleep, good sleep habits. We're then going to assess the severity and degree of associated disability, and we can think about prophylactic pharmacotherapy. We'll talk about that in just a little bit. If the patient has associated severe nausea or vomiting, we can consider pretreating the patient with an antiemetic or utilizing non-oral dosage forms for management of their migraine. We're then going to utilize a stratified care approach where the treatment of the headache is based on headache-related disability and severity. So for mild to moderate symptoms, we can consider simple analgesics such as acetaminophen, aspirin, and caffeine, and NSAIDs in the appropriate patient population. If there is an inadequate response to those, we can think about combination analgesics. If there is an inadequate response to those, we can move to the more migraine-specific agents, the triptans, dihydroergotamine, or ergotamine. For people who fail those, we then can move to opioid combination analgesics or butorphanol nasal spray. If patients have severe symptoms, we would skip the simple and combination analgesics and move straight to these migraine-specific agents, starting therapy with either a triptan or an ergotamine product. Attacks can vary in patients. They may have some that are mild to moderate and some that are severe. So your patient education can include what the patient should be doing to manage those more mild to moderate attacks and what they should be doing for their severe symptoms. So our first migraine-specific class of medications is the triptans, also known as the 5-HT1 receptor agonists. These include the medications that are listed: sumatriptan, rizatriptan, naratriptan, zolmitriptan, amitriptan, probatriptan, and elatriptan. These all work by binding to 5-HT1B and 5-HT1D receptor subtypes. They're going to lead to cranial vasoconstriction, inhibition of neuropeptide release, and reducing transmission and pain pathways. Sumatriptan, or brand name Imitrex, was the first member of this class. All of the other agents are considered second generations. Sumatriptan is the best studied. We do have the most data associated with sumatriptan. In general, all of the second generation agents do have better oral bioavailability and longer half-lives, which in theory could improve patient treatment consistency and reduce headache recurrence. All of these medications are available orally. I have included the other dosage forms that are available for each specific product. So sumatriptan is available orally as a sub-Q injection and also nasally. ODT is an orally dissolving tablet. We have rizatriptan and zolmitriptan available via those dosage forms. Sumatriptan is also available in combination with naproxen under the brand name of Trexamet. If patients fail one therapy, they may have success with another. However, they must have had some response to the first one. If they don't respond at all, they may not respond to any agent within this class. Upon administration, within 1 hour, about 30 to 40% will have 30 to 40% of patients will have 0 to mild pain. Within 2 hours, about 50 to 70% have 0 to mild pain. So these agents are fairly effective for the management of migraine. I want to just briefly review the pharmacokinetic parameters of some of the triptans. Important things to think about when choosing which specific triptan should be tried first in a patient. You want to think about its time to maximal concentration, or Tmax, time to onset, time to peak, and also its half-life. How long is it work? How long is it going to work for? We can try to pick an agent which will pair well with how the patient presents with their migraine. If they have very rapid onset migraines, we may want to choose a product that has a shorter time to peak. If they have migraines that have a slower onset, but maybe a longer duration, or that may recur several days in a row, you may consider ones that have a longer half-life because of their longer duration. So just a couple of things to point out here. Probatriptan and naratriptan do have the longest half-lives. They also do have slow onsets of action. These may be more useful in patients who have migraines with a slow onset and a long duration. Because the half-life of probatriptan is around 25 hours, it may be, or there is less risk of migraine recurrence with probatriptan. If you look at some of the subcutaneous injections or the nasal sprays, those typically do have a much faster onset of action, especially with the sub-Q injection that can start working in about 12 to 15 minutes. The nasal spray for sumatriptan, it does have a faster onset. However, it has a similar rate of response to the oral agents. Clinical response within patients is going to vary considerably. Individual responses can't be predicted. We can't say that, yes, patients will respond well to this agent and not another. So we can use the pharmacokinetic parameters to guide our initial decision-making process, but we also need to reassess to identify patient response. Once you have found an effective treatment and dose for a patient, subsequent treatments should begin with that same regimen. Adverse effects associated with the triptans are typically mild to moderate and relatively short in duration. These are consistent among the class, although again, patients may respond to each agent a little bit differently. Patients may complain of a sensation of warmth, fatigue, dizziness, tingling, somnolence, and flushing. This class of medications is less likely to cause nausea than the ergots, which we will talk about next. Some patients may experience chest symptoms. This can include things like tightness, pressure, heaviness, or pain in the chest, neck, or throat. They can occur in up to 15% of patients. It's very important to educate patients about this because it can sound scary if patients aren't aware that these things may be coming. Adverse cardiac events are very rare. There have been very isolated cases of myocardial infarction or coronary vasospasm with ischemia reported. However, typically these chest symptoms are not specifically cardiac in nature. With the sub-Q injection, patients may also experience injection site reactions. Intranasal formulations can lead to some nasal discomfort or some taste perversion. The tingling and chest tightness is the worst with zolmitriptan and sub-Q sumatriptan or Imitrex. There is a lower incidence with naratriptan. I have heard of naratriptan being referred to as the gentle triptan because it's typically very well tolerated. Because of the potential for chest symptoms and because of the vasoconstriction that these agents do provoke, these medications are contraindicated in patients who have ischemic heart disease, so any history of angina, previous myocardial infarction, if they have uncontrolled hypertension, cardiovascular disease, specific migraine types, or if they've received another triptan or an ergot preparation within 24 hours. We do need to use them cautiously in patients who are at risk for unrecognized coronary artery disease. If you're starting these in a patient who is a postmenopausal female, an older male, or who has uncontrolled risk factors, you may want to do a cardiovascular assessment. In this case, you also would want to administer the first dose in the office or under medical supervision so the patient can be monitored for any potential adverse effects. Drug-specific contraindications are listed. We do have some that we need to be concerned about: renal function or hepatic function or drug-drug interactions. There is a potential for serotonin syndrome with all of the agents. However, because these are used intermittently, the risk for serotonin syndrome is low. However, if you do have a patient who is on multiple other agents that may increase serotonin, you do need to very carefully measure risk versus benefit. Our other migraine-specific agents are the ergot preparations. These are non-selective 5-HT1 agonists that constrict intracranial blood vessels and inhibit the development of neurogenic inflammation in the trigeminal-vascular system. These include dihydroergotamine, ergotamine, and combination of ergotamine and caffeine. The oral formulation of dihydroergotamine and ergotamine is very poorly absorbed, which is why you see these as nasal spray, injection, sublingual, and suppository formulations. There is one formulation, the ergotamine and caffeine combination, that is available orally. Caffeine was added to increase GI absorption. It also has the potential to potentiate analgesia because of its effect on vessels. It will cause vasoconstriction. Caffeine does interfere with sleep, so that is something to keep in mind, that patients may not be able to sleep, which is one way to cure their headache. Nausea and vomiting is relatively common with these agents, and it's due to their stimulation at the chemoreceptor trigger zone. We can consider pre-treating with an antiemetic if patients are receiving ergotamine or the injectable formulation of dihydroergotamine. The majority of these additional adverse effects are occur because of how vasoconstricting these agents can be. So patients may experience similar chest tightness as you see with the triptans. They may experience numbness or tingling in the fingers or toes, an increase in blood pressure. Aside from that, those vasoconstricting adverse effects, we also can get some GI effects such as abdominal pain or diarrhea, and some CNS effects like weakness, and fatigue. With the nasal spray formulation, we can get some nasal type symptoms like rhinitis or pharyngitis. Ergotism can occur with extreme cases, and it's a very severe peripheral ischemia, which could include cold, numb, or painful extremities, and this can lead to gangrenous extremities as well. This is a rare side effect, but a potential because of the vasoconstriction. These medications are contraindicated in patients who have coronary, cerebral, or peripheral vascular disease, uncontrolled hypertension, who are septic, have liver or kidney disease. They are a pregnancy category X, and they should not be used within 24 hours of triptans because of that combined vasoconstrictive effect. Patients who have migraine may also experience gastric stasis, nausea, and vomiting. Gastric stasis or delayed gastric emptying may have a decrease in absorption and efficacy of their oral medications. Metoclopramide is an option that may help to speed the absorption of analgesics because of its effect on gastric stasis. Many of our abortive agents can cause nausea in addition to the nausea that may be caused by the migraine itself. Because of this nausea, we may be unable to use the oral route, so we do need to think about what medications are available in alternative dosage forms. We do have some orally dissolving tablets, nasal sprays, sub-Q injections, suppositories, etc. Patients should be counseled to begin antiemetics at the first sign of headache to reduce nausea, prevent vomiting, and potentially allow patients to take their medications orally. Some antiemetic options are listed for you. The migraine-specific medications that may be most likely to cause nausea would include our ergotamine formulations, opioids as well. We also can think about route of administration of our antiemetic. If patients aren't able to take things orally, there are some formulations that are available as suppositories. So let's review our case. RA is a 28-year-old male who calls to the clinic for advice. He explains that he woke up this morning with a bilateral frontal headache. He took 650 milligrams of aspirin. Initially, he had no symptoms other than head pain. Although the sky was overcast, he did require sunglasses. While driving to work, he became nauseated and his head pain intensified. He rated the pain as 7 on a scale of 1 to 10 for the worst pain imaginable. Sounds didn't bother him, however, he was unable to take the stairs to a second-floor office without aggravating his headache. Soon as he walked in the door, his boss reminded him of an important meeting that afternoon. That prompted him to call you to see what else he can do. So what do you recommend based on the case? So based on his functional impairment, his current pain score, he is having some nausea associated with his migraine. It sounds to me that this is a moderate migraine in severity. You can emphasize to the patient the importance of treating early, which it sounds like he did because he did take 650 milligrams of aspirin right away. For migraine, patients can take up to 1 gram or 1,000 milligrams of aspirin. We could also think about using an NSAID, depending on how long ago he took his aspirin dose. We could think about using some Excedrin migraine, the acetaminophen, aspirin, and caffeine combination tablet. Not sure if he has a triptan available, or if you would be able to pick up a prescription for a triptan. If that would be within your scope of practice, that would be an option, as would an ergot. So all of those would be reasonable things to talk to RA about. So let's talk through migraine prophylaxis. About 38% of patients with migraine need preventive therapy. However, only 3 to 13% currently use it. Goals for prophylactic therapy. Our goals are to reduce the attack frequency, severity, and duration, improve responsiveness to treatment of acute attacks, and improve function, reduce disability, and improve quality of life. When should prophylactic therapy be considered? You have to think about migraine frequency and severity. So patients who have recurring migraines that in their opinion significantly interfere with their daily routine despite acute treatment. For frequency, patients who are experiencing more than 2 migraines per week. Patients who have contraindications to have failed or have had serious adverse effects or overuse of acute therapies. Patients who have headaches that recur in a predictable pattern. Patients who have menstrual migraine would be an example here. Certain migraine variants may respond well to prophylactic therapy, and then also patient preference. If a patient asks to be placed on prophylactic therapy, that's a reasonable option as well. We want to choose an agent based on side effect profile and a patient's comorbid conditions. We also need to ensure that we're giving an adequate trial of medications. This would be about 2 to 6 months for full efficacy. Patients may experience some benefit within the first month of therapy, but they really do need up to 6 months for full prophylactic benefit. Drug doses for migraine prophylaxis are often lower than those for other indications. Patients should be monitoring and reevaluating on a regular basis. They can do this by keeping a headache diary. If after 3 to 6 months the headaches are well controlled, you can consider tapering and discontinuing that prophylactic therapy. We want to start low and go slow. We also need to be cognizant of the patient population that we're dealing with. Many women or many patients who experience migraines are women of childbearing age. So we need to think about those women who are pregnant or who want to become pregnant and the potential for adverse fetal effects. All of our migraine prophylactic agents are approved for something else. The bolded agents are those that have FDA approval specifically for migraine prophylaxis. So medications within the anti-epileptic class include divalproex, sodium valproate and topiramate, and then propranolol and timolol. The bolded agents are the ones that have been FDA approved. These all have level A recommendations from the American Academy of Neurology. Efficacy appears to be similar between all of the agents, but we definitely do need more research in this area. So you're going to be choosing your agent not specifically on efficacy, but more on adverse event profiles as well as patients' comorbid conditions. It may seem odd to see a triptan listed as a prophylactic agent, as we just discussed them being used for abortive therapy. They can be used specifically for ovatriptan because of its long half-life in more of a menstrual migraine type picture. They would be used short-term prophylactically around the time in the cycle that the woman knows that they experience their migraine. Medications that are probably effective are listed here. There is not as much data for these, but there is some data to support their use. Again, NSAIDs and triptans would be used for short-term prophylaxis of menstrually related migraines. Over-the-counter agents that do have probable efficacy include magnesium. Magnesium would need to be dosed at 300 milligrams to be effective for this indication, and then riboflavin needs to be dosed at 400 milligrams. This is vitamin B2. Medications that are possibly effective, these are level C recommendations. So let's look at a treatment algorithm for prophylactic migraines. If we have a patient who meets criteria for migraine prophylaxis, we then would look at specifically what their comorbidities are. So if we have patients who have menstrual migraine or headaches that recur in a predictable pattern, we can consider NSAIDs. If they're otherwise healthy or do have comorbid hypertension, angina, or anxiety, we can consider a beta blocker or verapamil. If they have comorbid depression or insomnia, we can consider a tricyclic. If they have a comorbid seizure disorder or a manic depressive illness, we can think about an anticonvulsive. If other agents are ineffective, we would then consider combination prophylactic therapy or referral to a neurologist who specializes in headache. Populations. As I previously mentioned, migraines do often occur in women of childbearing age, so we do need to think about how do we manage migraine in a pregnant patient. Non-pharmacologic methods are going to be the best. If patients do need to have some type of pharmacologic treatment, acetaminophen is going to be the safest. NSAIDs should be avoided. Opioids are second line. We can think about using some antiemetics or corticosteroids. Triptans are category C, ergots are category X, and then from a prophylactic perspective, both beta blockers and calcium channel blockers would be the safest, although those do have a category C rating.